herniation is very safe. It can protect the nerve root when we use the high-speed drill around the nerve root. This is a flav ligament detector. I use this detector to detach the flav ligament. Then I can do the en bloc removal of the flav ligament. This is a protectable retractor. I can insert along this retractor. I can insert the cage along this retractor. And this is a double nerve root retractor. It can protect the transverse nerve root and the exiting nerve root at the same time. This is cervical protective sheath retractor for the drill. When we do the cervical procedure, this is a cage transverse tools. The flav detector, another type of the flav detector, when we detach the flav ligament from the upper margin of the lamina. This is the fasciotomy tube to open the fascial membrane and keep the outflow fluently. And this is also fascial open tools. We often do the suture work. We do the suture of the dura and the suture of the annular fibrosis. And the fascia tuber is used for the suture when we make the node. This is the bone wax dauber. And this is the marker. The operation video. This is the discectomy video. This case is about L5 and S1, the right side case. First, we clear the soft tissue in the interlaminar space, and is very efficient when we use this big one to clear the soft tissue. Then I use the shiver bone to mix in the lower margin of the lamina. Then I use the calcium punch to do the bone work until we find the proximal insertion of the flav ligament. I use this small size radio frequency to do the bleeding control. Then I remove the ipsilateral flav ligament by the calcium punch piece by piece. Now we can see the discal fragment is located in the shoulder area of the nerve root. Then I change the endoscopy and the instrument portals and deal with the disc space. Now, at last I release the S1 nerve root. This is a URBD. We can do the decompression of the three nerve roots. This is the contralateral side, the exiting nerve root. I rotated the endoscopy. We can see the opposite lateral nerve root and the disc space. Then I rotated to the contralateral side. We can see another nerve root. The paraspinal approach. This case is about L5 and S1. We can see the tip of the S1 SAP and the TP isthmus. And after removing the tip of the SAP, I can see the foraminal flav ligament. After removing the flav ligament, we can see the exiting nerve root and the radicular artery. After removing the disc fragment, the nerve root have been released. This is a ULIF procedure in the L4 and 5 by the left approach. First, I use the osteotomy to remove the IEP piece by piece. Then I can see the surface of the LSAP under the IEP. I use the knife to open the annular fibrous. And insert the reamer to deal with the disc space. We can see the end plate clearly in the disc space. The 90-degree radio frequency is also a good choice to deal with the disc space. The bone graft and insert the cage. This is the annular fibrous suture case. First, we do the discectomy. Then I insert the needle into the disc space and injections or saline water to push the line into the disc space, and I pull out the line through the fissure, and as the same method, I pull out another line. Then we make the note. This is another method for the annular fibrous suture, especially for the disc fragment go downward. I use the anchor and a T-bar line for the suture. This is a video shows the procedure. The tear is located at the low margin of the disc space. Then I insert the T-bar line inside the disc space. And inside the anchor nail on the bone. Then I make the note. By the note pusher. It is often used in the shoulder arthroscopy procedure. The cervical keyhole technique, we can pull out the disc fragment in the axillary area. we can touch the pedicle with the medial margin of the pedicle of C6. This is a thoracic case for the decompression of the OLF. We can see the calcified, the dura. So take home message, I think the UBE technique is an excellent technique because we can use the big instruments and different the high-speed drill, so we can deal with the difficult spinal case, including the stenosis, disc herniation, and the revision case. But we must know the concept of the UBE and how to use the instruments. And if you master the technique of the UBE, I think you can do many kinds of the difficult spinal case. Thank you for your attention. I feel very sorry for the problem of my computer.
So we are going to the end of this meeting. So I think today there's a lot of very interesting presentation about all type of surgery you can do by endoscopy, monoportal, biportal, destendo, and I hope in your future we can have a real meeting with no COVID problems. So thanks a lot to all speakers, and I hope to see you in real life in near futures. I must say thanks to Bones Company to organize this meeting. So again, thanks to all speakers to join us today to speak about endoscopic spine surgery. Thanks again.
Thanks very much, Dr. Chalali, and thanks very much, Professor Jen and Charles, and the French team, also our sponsor in the France-Russia company. Thanks very much.
Thank you all. Thank you very much. Goodbye.
Thank you, Chris. Good job. Thank you, Dr. Chalali.
Thank you, everybody. Good job, good work for the French committee, the Bones team. Everybody, thank you for the attention. See you the next time.
Thank you, everyone. See you next time.
See you. Thank you.